So, treatment approaches. Just as we have remediation and adaptation or compensation, which we put together to be the term modification, right? So just as with any other aspect of occupational therapy intervention, we have these different aspects. We have them in approaching issues around sexuality and sexual identity. So the first is health promotion. So we're always looking for our clients to be safe and to experience a sense of well-being, etc. And then we can talk about changing some of the things that are going on with them. If they're having trouble with various positions, if they're having trouble with pain, if range of motion is of issue, those are just some examples. We can work on actually remediating those. It would be the same issues that we would seek to remediate in any other area of occupation. And then we can make modifications, which include both adaptations, potentially equipment, and compensatory strategies. So if a person absolutely cannot engage in a particular aspect of sexuality, how can we change around the activity so that they then can participate? Health promotion with youth. So we're going to break these down now. The first is about safe sex practices, which I brought up. That both has to do with sexually transmitted diseases, the more innocuous gonorrhea, chlamydia, syphilis, and HIV/AIDS, etc., and birth control awareness. Issues of consent. So we want to be sure that if our youth are sexually active, that they are also actively consenting. They're not being pressured, they're not being coerced. There's also the aspect of someone who is overage and underage, and so that may be of issue. And then finally, we want to help our youth to maintain positive self-esteem or even raise their self-esteem around these issues and their sense of self-determination. Let's see. In the notes, it's also important to note that we're going to differentiate between personal sexual behavior or masturbation and sexual behavior with others, and what is, and how we work with that. Also, the location and timing of sex, and the risks. When we think about remediation for youth, we think about restoring skills such as motion, range of motion, strength, endurance, communication, social engagement, etc. And clinicians can work on these physical factors, like I said, just like they work on any other on physical factors for any other reason, with the goal to increase, a person's ability to engage in sexual activity or increase their satisfaction. And increase their sexual satisfaction. Examples include increasing strength and range of motion after carpal tunnel surgery so that a client can weight bear during sex, or can engage in sexual activity without pain. Focus on increasing endurance to maximize sexual satisfaction and participation. And practicing, and this is kind of a whole different thing, right? That's not a physical factor per se, but practice asking people out to reduce social anxiety that may arise. So there's a whole range of aspects that we can look at that would be of benefit to our clients. Then we look at modification, right? So we looked at health promotion, remediation, now modification. So modification either requires changing the environment or changing the requirements of the activity. It could include some or any or all of the following examples. Extra lubrication, right? So artificial lubrication to reverse the effect of dryness, vaginal dryness, positioning devices, promoting energy conservation techniques, information about using personal pleasure devices, either for one's own pleasure or someone else's. Let's see, modified positions. So that would account for any kind of physical restrictions that cannot be remediated. It just is your baseline. And then finally, promoting intimacy in place of sexual intercourse. So if intercourse or other kinds of active sexual activity are not possible, how can we work around that? How can we promote satisfaction and excuse me, and addressing desire without actually having the sexual activity that may be expected or a person may be thinking is the only way to engage in sex. Now we're going to turn to something called the explicit model, and it is a guide to working with clients on issues of sexuality. This one is updated in 2006 from a 1976 version. So here's a nice visual that I found, a visual model of the model, and it includes the four aspects, permission giving, limited information, specific suggestions, and intensive therapy. We're going to go through these one at a time, and then what I'd like you to do is to encourage you to come back to this model and have a look at it in light of your new knowledge around the parts of the model. All right, so the first part is permission. And what we want to do is provide affirmation to our clients that it's okay to talk about their thoughts or their concerns or their questions pertaining to sexuality. So we first want to really say, hey, it's okay and I'm a safe person. Providing affirmation to clients is appropriate and it can be addressed by a healthcare practitioner. And that is definitely including occupational therapy. It's not enough to just give somebody a pamphlet or a resource when we actually are face-to-face or right now when we're telehealthing, having an actual person to talk to can be very helpful. But we want to get permission. It assists with building rapport. It assists with the trust. And the client may say, no, thank you. I don't want to talk about issues related to sexuality, but thanks for asking, right? So we're gonna approach it in an open-minded, permission requesting way. And again, there's more information about this model in the presenter notes after each slide. So do check it out. The second aspect of the explicit model, is limited information. And that may seem kind of counterintuitive at first, but how it works is that we want to explain the effect that the individual's disability can have on sexuality and sexual function, but we want to limit it enough so that it's helpful. So think about it. If sex is a little bit stressful or a little bit awkward to talk about, and then I give my client everything under the sun in terms of information and knowledge, it'd be very easy to get overwhelmed or to feel even more awkward. If, on the other hand, what I'm doing is sharing the information that's really relevant with that person, then it can make the situation a lot more approachable and it can help that client to actually feel comfortable and be able to engage in the process. The next step with the explicit model is specific suggestions. So what we're going to do is just like we would do with any other area of client need, we're going to explore it somewhat and figure out, okay, what's up, and then make some specific suggestions that are directly related to our to that questionnaire that we gave them, to any follow-up questions that we might have asked and what their answers are. And again, we're going to tailor it more narrowly than broadly to make it really relevant and usable for the client. So specific problems might be positioning suggestions, right? Or specific solutions, excuse me. So positioning suggestions for the individual that has low endurance, right? It may be something as straightforward as that. So they don't need to know about 101 positions. What they need to know about is how can they maximize their energy conservation while they're engaged in sexual activity. So we'll be specific about it. We will also know that this is the highest level of input that just your average run-of-the-mill OT is trained for, and we don't go past this, right? So we are not sex or sexuality therapists. And again, we may get special training for it, but most of us don't have that training. And so we're going to consider this to be sort of the soft stop of our area of expertise and our scope of practice. Now, beyond that, the next phase of the explicit model is intensive therapy. And it is used when there's some serious issues, there's some abnormal coping patterns, or there's some things that are just really intensive. And it requires a health professional with advanced training, not an OT. So we're not going to be the front line for providing intensive therapy. What we're going to do is refer out and turn that over to someone who has that training and expertise. That might include a neuropsychologist, a sex therapist, or a psychosexual counselor. The final piece, and this is not like an official stage, but the explicit model incorporates reflection and review after all the stages of intervention, much like we do a reevaluation in any area of OT. So it increases our opportunity for effectiveness to look back and say, how did it go? What happened? Where are we? And then to review and say, okay, well, where do we need to go from here? Are there other issues that are coming up? Do they need a referral? Do they need more information? Do they need more resources for supplies? Is there something we can do with working with a caregiver? So there's a range of reflection and review options depending on the needs of the client. We also when we go into this reflection and review with our client, we want to get permission again, right? So that first stage, we want to get permission again and say, okay, I'd like to talk to you again about some of the issues related to sexuality and see where you're at now and see if there's anything else you need. Is that okay, right? Is that something that you would like? At this point, we're going to transition into looking at 3 different clients who have differing conditions, and we're going to look at some of the specific issues that might arise. I find it's helpful, we've talked generally about sex. We've talked about factors and ideas and intervention and evaluation and all of that, but we haven't really applied it to clients. So this part is to give you a picture of, okay, with a client who has ASD or an autistic client, what are the issues that might arise? Now, do know that these are, of course, not applicable to everybody with a particular condition, right? So that's a caveat off the top. We can't generalize to everyone. So what we're doing is we're taking a somewhat generic client for the purposes of teaching. There are 2 really great little radio pieces that are in the presenter notes that I think you'll really enjoy. Actually, 1 radio and 1 article, and just really cool about working with clients with autism and the experience of sexuality for autistics. So check that out if you have time. All right. So, issues of sexuality with a client who has ASD. Settings for sexual behavior may be difficult. We may need to confer with our client about what's appropriate and what's not, especially with regard to public places, right? So the person may not have access to a private place and they want to have sex, and so they default to somewhere that's more public. So really looking at, okay, what's appropriate, what's going to be effective and safe in terms of setting could be important for someone with ASD. Also, sexual interest in others. So our autistic clients may or may not be interested in sex for a variety of reasons. And not to have a total spoiler, but one of the things that's brought up in this little radio piece is that the young man who is dating a woman who is also autistic has some sensory sensitivities, in particular to tactile. And so kissing feels very wet and very smushy and very icky, right? So sexual interest may be of issue for a variety of reasons, and we want to be sure that our clients know that their interest or lack of interest is all okay, right? And if they are interested, to be in collaboration with them around that. And if they're not, to really be reassuring that that it also is an absolutely fine way of being. We want to be sure that our clients who are autistic have an awareness of inappropriate advances. So at the beginning, I said, it can be much more likely that our clients with disabilities are preyed upon around issues having to do with sex. So inappropriate advances, whether that means somebody that is much older than them, somebody who doesn't have a genuine interest in them, but is, doing whatever twisted thing. So we want to be sure that our folks with autism are aware, and they're not being gullible or taken in by inappropriate advances. We also, along with that, want to help them develop some strategies and some responses to inappropriate advances so that they're not taken unawares and they don't freeze or flee the situation, but rather deal with it so that they can maintain their self-esteem and self-determination, and also so that they can feel empowered. So responding to advances is beyond the scope of this particular lecture, just for time's sake, but there is a link that talks about how to respond to inappropriate advances. In short, we're going to potentially role play that. We're going to help empower our autistic clients to make those responses and assure them that that is absolutely appropriate and okay. The next diagnosis we want to talk about is issues of sexuality with a client who has an intellectual disability. Folks with intellectual disability may have very typical sexual interests and the desire to explore. So regardless of their IQ, sex is working just fine. They are, however, at an increased risk of sexual abuse, primarily due to the fact that the prefrontal cortex and the executive functioning, so decision-making, inhibition, and taking care of oneself, right, very proactively, can be a part of the intellectual disability. Again, beyond the scope of this to dig deep, but there's a great linked radio piece about sex ed for individuals who have intellectual disability and what that looks like and how empowering it can be. So do check it out. Also, just as our autistic clients may not have a good repertoire of understanding or responding to sexual advances, same thing with the client who has an intellectual disability. And we want to work with them to be able to differentiate an appropriate versus an inappropriate advance, and also to respond proactively. And finally, again, appropriate settings for sexual behavior. So, with our clients who have disabilities, they may or may not be living independently, right? And so, you can't just go to your house and have sex. You might not have a driver's license, so you can't even go to your car. So, how does a person navigate that, and how do they navigate it both safely and appropriately? We're going to now talk about issues of sexuality with a client who has a traumatic brain injury. This is, again, a different set of issues, and they can be pretty debilitating, right? So now we're talking about the person who, to some point in their life, was functioning typically, and now they've had a traumatic brain injury, and so there are changes that have taken place. Some of them transient, others chronic. So sex drive may change. There may be reduced libido or sexual drive. There may be erectile problems. 40 to 60% of men either have temporary or permanent impotence after injury. There may be an inability to orgasm. 40% of men and women report difficulties in this area. And there may be a reduced frequency of sex. That could be due to the disability, to depression, to the breakup of a relationship, or to other sexual problems. Personality might change. So the person may come back to kind of more a higher level of function, really a kind of a different person, right? With a different personality. And so that could be problematic, especially if they have a partner that they had before their accident, and now that person is living with or dating someone who is very different. There's also decreased decision making and impulse control, which, as you can imagine, may lead to, again, issues around setting. Who do you say yes to? Who do you say no to? About advances towards others. All of that can enter into it. And inappropriate expression of sexuality. So this has to do with lack of impulse control, whereas with our client with intellectual disability, it was more a lack of executive functioning and decision making. But all the same, it gets us to the same place with the potential of having sex in an unsafe or inappropriate place, public place, or with inappropriate people. So those are some things we want to keep in mind with our client who has a traumatic brain injury. When we meet in class, we will be discussing these issues. So please do look at the PowerPoint, go back and check through, jot down your questions and any other factors that you would like to know about, any comments that you have about any of this, and I will see you in class. If you're interested in where the information came from, here are the references for this particular slide deck. And I thank you for your kind attention, and I will see you real soon. Thanks, everyone. Take care. Bye.